Good afternoon. Good afternoon. My name is Henrique. I'm one of the core trainees from catering. I understand I'm the last presentation today, so I'll try to be as quick as possible. So the topic of my presentation is from operation room to perioperative medicine, the unmatched training needs. So what am I talking about? In the past 2 decades, there has been an ever-growing discussion about the changing of the ethnicity scope of work. The current curriculum was established in 2010. It received an update in 2016 to include a new perioperative medicine unit of training for each basic, intermediate, and advanced levels, establishing the concept of perioperative medicine for the very beginning of the training program. The curriculum is under revision, but considering the effects of the last update, we believe we need to go beyond it. So why am I talking about that? The pathology, the surgical trauma, and the anesthesia, they all contribute to the patient's physiological disturbance and may lead to complications postoperatively. Accordingly, the postoperative care should be seen as a shared responsibility among surgeons and anesthetists. It's kind of our job to protect patients from them as well. So it's well recognized that several factors outside theaters, even before theaters, largely influence patients' outcomes. For example, it's one of the topics of my poster presentation, early detection and correction of anemia in perioperative neck-of-femur fracture may reduce mortality. So it's a good way to show how important for us to have a role before and after surgery as well. So in 2015, there was a benchmark editorial from the American Society of Anesthesiology Journal, where they advocated the formal change of the name of the specialty to anesthesiology and perioperative medicine, claiming that there lies the future of our specialty. Not surprisingly, in the USA, during the anesthetic residency program, over a total of 48 months of training, you have 20 months of non-operating room rotation. So almost almost half of the training is involved in non-operating room rotations. This editorial was followed by an editorial in our anesthesia journal, and where the authors advocated, using their own words, the migration of the anesthetists from operation rooms, both upstream and downstream. So nevertheless, all this literature evidence, or literature opinions, from my training experience, albeit short, it seems to me that the anesthetic trainee exposure to pre- and post-operative care seems yet very limited. In addition to maybe compromising patient outcomes, it certainly carries a negative educational aspect. The lack of follow-up of patients beyond the recovery room at best, when we see them in recovery room, represents a crucial waste of opportunities, once this is an acknowledged self-method of learning and a unique feedback tool of our own practice. So how to say if my impression is really true? So I ran an online survey last month that was sent to all trainees across East Midlands Schools of Anesthesia. I understand a few of you have replied here, and I would like to thank you for that. And I understand the limitations of online survey, but it was a feasible way to have a snapshot view of our training situation. So as main result, we got 37 responses across 11 different hospitals in our deanery, across all training grades, with a good proportion of registrars to core trainees. As main findings, most trainees only occasionally, defined as less than twice a year, do pre-op clinics. And post-operatively, the situation is not better either. So most trainees only occasionally, defined as monthly, visit patients in the ward post-operatively, and we hardly ever are involved in pain management when patients are back to the wards. In terms of feedback from our practice, besides these lost education opportunities that I've mentioned, also what we got from our survey is that we hardly ever get any feedback from our colleagues, including surgeons or anesthetic consultants, about the clinical evolution of our patients. So we're missing by not following them up, and we're also not hearing anything back for anyone that could contribute to our personal improvement, personal development. So paradoxically, when trainees are asked how confident they are to estimate the incidence of post-operative nausea and vomiting, about the opioid requirements of patients when they're back to the wards, and about deficiency and lack of side effects such as motor blockage when we perform regional anesthetic techniques when these patients are back to the ward. Most trainees rate their confidence level in a scale of 1 being minimally and 5 being completely confident as 4. So we have a high level of confidence of how the patients are going post-operatively. So despite this paradox of not following up patients but still feeling very confident that we know how they are progressing, when we asked the trainees how would they classify their role as being perioperative physicians, most trainees would rate their role in this scale of 1 being minimally and 5 completely among the 1 to 3. So we classify as role as being minimally to modest as perioperative physicians. So some subjective response to our survey show that the trainees identify lack of time, strict adherence to curriculum, not being invited to, conflict avoidance, and seeing the patient as responsibilities of the consultant as barriers for not fulfilling this perioperative physician role. So the conclusions and my take-home message is that the results show that it may be necessary more than the redefinition of curriculum to actually promote changes towards a perioperative medicine training. It is also necessary a change in our culture, or to use a more fancy word nowadays, our mindset, and change the way the road is designed. The current situation is that the trainees are minimally exposed to out-of-theatre environment. I would like to thank you everyone, and please consider leaving your feedback by scanning the QR code. Thank you.